Okay, good evening everyone. My name is Dr. Maheshwar Naidu and we are doing our first live CME talk, Zululand Continuing Medical Education. And our topic for today is a paradigm shift in varicose vein therapy. The first lecture will cover understanding venous disease of the lower limbs. Now, before we get started, I just thought I would explain a little about the format. What I am trying to do is to offer an alternative format to the typical evening dinner CME meeting or early morning breakfast CME meeting, which people have to rush to before and after a busy day at work. Also, a lot of the doctors in rural areas, Zululand is a vast area, and it is not possible for them to travel to the more central areas where the CME meetings are typically held. So this solution is very inclusive. Anyone who wants to join in may do so. And you are able to watch this broadcast from the comfort of your own home. And you are, to get the CPD points, you are required to complete a 5-question MCQ, which I will distribute the link to at the end of the lecture. So other than the MCQ, which some may find a little daunting, but if you listen to the lecture, it really will not be difficult. And the lack of any dinner being provided, this solution should hopefully be quite useful. I do hope to present the same talk at a live venue later on, but I will obviously let you know in the event that you do not like this particular format. I will also try and make an effort to present this in a live setting as well. Please note that my number is at the bottom of each of the slides, so if you want to send a message, please send it on WhatsApp. I'm not able to answer calls because I'm obviously doing a live broadcast. I will try and check my WhatsApp if, for example, the volume's not loud enough, or if there's any other type of a problem. Please let me know and I will hopefully be able to resolve it. Also, if you have any questions, please feel free to send them via WhatsApp. You can also send questions on the WhatsApp voice recorder app or voice note. That way I can play back the voice note and we can actually have everyone listen to the question, and then I will try and answer it. So let's see if we can get this going, and whether everyone is going to, I hope everyone is going to enjoy this format. Okay, so varicose vein therapy. Let's do a little bit of epidemiology. Firstly, there's a new word called phlebology. And this is an evolving medical subspecialty devoted to the disorders of veins throughout the body, not only in the lower limbs. A phlebologist is a medically qualified doctor who has undergone further postgraduate training to expertly diagnose, treat, and where possible, prevent any form of venous disease. The typical venous conditions that we see are varicose veins, as exhibited on this photograph on the bottom right of the screen. Clotting disorders such as deep vein thrombosis and complications thereof, which is pulmonary embolus, for example. Vascular birthmarks, the hemangiomatous, large vascular hemangiomatous birthmarks, which can be very troubling to a young mother. And then, of course, leg ulcers, which we really have difficulty managing. And the advantage or the great thing about this new phlebology subdiscipline is that there are actually solutions to these chronic ongoing ulcers. They can be effectively treated, and patients actually go home very happy with the outcome. The phlebology in South Africa has only really taken off over the past 10 years. However, it has been an established medical specialty, or subspecialty, I should say, in Europe for more than 50 years. So while we might consider it to be something relatively new, it has been around for quite some time. Okay, then how common is varicose vein disease? Doctors in practice will know that there are many patients that come in, and the estimates are that up to 30% of the population suffer from varicose vein disease or the associated complications. The symptoms that we should be looking out for include heaviness, aching, burning, stinging, throbbing, swelling, and leg cramps, as well as restlessness of the lower limbs. There may be a skin rash on the leg. Small blue veins may be visible on the feet. There may be lower leg discoloration, pigmentation, and scarring. And this is usually secondary to advanced vein problems. If all of the above are left untreated, then ultimately leg ulcers develop. And once they develop, they are very difficult to treat. They are also very painful and uncomfortable for the patient. They may have a foul smell if they get infected, and they generally cause the patient a lot of morbidity. Many elderly patients suffer from leg ulceration. The management of these ulcers costs the community millions of dollars, or in our instance, rands, every year. And prevention can be achieved by treating abnormal veins before the ulcers develop. Okay, a little bit of a break before we go on. So just to mention that varicose vein disease is extremely common. There are many patients who've had it for so long that they just take it for granted. They sometimes believe that they have arthritis or some other condition, and they continue taking analgesia on a regular basis. So if possible, try and just check your patients carefully and ask them again, those that have been on chronic analgesia for lower limb pain forever, just check that there aren't some treatable varicose veins or telangiectasia, spider veins that we could treat and thereby reduce the patient's suffering and reduce their analgesic intake. Moving on to anatomy and physiology of the lower limb venous system. The normal circulation, there is a calf pump, the muscles in the calf and the foot as the patient is walking. They actually squeeze the veins, and the deep veins carry the blood back to the heart. The superficial veins carry the blood upward towards the heart. However, they tend to drain into the deep system before the blood goes back to the heart. So the superficial veins drain into the deep system via perforators. Right? These are called perforators. And all of these veins have unidirectional valves. So the valves allow blood to flow in the direction of the arrows. So the perforators, for example, as I mentioned, will allow blood to flow from the superficial venous system through the perforator and into the deep venous system. Sorry, I just want to check my WhatsApp to see if there's any questions coming through. Okay, nothing. Right, then in terms of abnormal veins, so we've looked at the normal veins or the normal venous system in the previous slide. We are now going to look at the three types of abnormal veins. and these include spider veins, which are also known as telangiectasia. These are fine red capillary veins. I'll show you an enlargement of the photograph just now. The large blue veins are called reticular veins and are slightly deeper below the skin surface. And then the ones that we are often faced with, and those are the large varicose veins, and they may actually bulge through the or under the surface of the skin, as shown in this photograph. Now I have a question. There's something common to all these patients. If anyone can see what I'm referring to, please post your answer on WhatsApp. You can post it directly to me on the number at the bottom of the screen, 0835568774. Okay, so this is an enlargement of the photographs on the previous slide. The spider veins or telangiectasia tend to be more reddish. They're very fine. There is also some bluish discoloration, and they tend to be just under the skin. If you were to palpate or run your hand over the veins, tend to be more bluish in color. They are also impalpable, and they are a little bit deeper than the spider veins or telangiectasia. Okay. The complaint about the volume. Let me just try and adjust the volume for a second. It's actually on full at the moment. I'll try and speak a little bit louder. Okay, so these are the reticular veins, which are a little bit deeper, also impalpable. And then the very obvious varicose veins are hugely dilated and are actually palpable under the skin of the patient. I posted a question just now with respect to what is common between these three patients. Let me check again if anyone has answered. Okay, no one has answered yet, but just going back to these three pictures, right, the common thing here is that all these patients are fair-skinned or white, right? It's not to say that patients of darker skin colors don't get varicose veins, but the fact of the matter is it's easier, much easier to see these veins in the fair-skinned patients, right? Which is why these photographs, which I've got from online resource, show fair-skinned patients, and it's easier to see. Nonetheless, we have to be able to detect these in our dark-skinned patients, and there are ways to do that. There's a special vein light which we use to show these veins up more prominently. Right, now what this means is that because our population is predominantly dark-skinned, we must be more conscious of the varicose veins, and even if it's not obviously visible, we should ask for the symptoms from the patient, and then if they are positive, if the patient does complain of symptoms suggestive of lower limb vein disease, then we should order the appropriate investigations, which I'll come to shortly. Okay, moving on to the pathophysiology. The abnormality here is that the veins which become varicosities or enlarged have weak walls. These veins collect and contain more blood. The blood in turn causes further distension, right? And because of this distension, the valves which work in a unidirectional manner, these are the valve cusps which come together. So as the blood goes up towards the heart, the veins allow them to the blood to pass through. But if the blood goes anti-gravitational, goes down, the veins tend to snap together when they're working normally, and this prevents the blood from going back down. Now, if the entire vein becomes enlarged, distended, and swollen with blood, the valve cusps, don't meet, right? They don't come together, and they tend to allow blood to go in the opposite direction. So if you've got veins in the superficial system, the blood goes down. If you've got perforator valves which are now not working properly, instead of going from superficial to deep, the blood now goes from deep to superficial, which is abnormal. Then at the junction between the great saphenous vein and the femoral vein, which is called the saphenofemoral junction, if you have a valve that's not working there, then you get saphenofemoral disease. Okay, and the entire condition is called venous hypertension. Okay, now on all of the slides that I'm presenting, please pay special attention to all text that's in red. Backflow from the larger veins into the smaller capillaries causes their distension and the formation of the so-called spider veins. So there has to be some abnormality for the spider veins to occur. They don't just occur on their own. And the treatment of spider veins in the presence of underlying varicose veins is not considered appropriate unless the underlying problem is also treated. So the flow diagram just summarizes everything. The etiology may be primary, secondary, or congenital, but the dilated veins leads to venous valve dysfunction. The valve dysfunction leads to further dilated veins, and this becomes a vicious circle. And this then leads to chronic venous insufficiency. The chronic venous insufficiency in turn leads to the symptomatic or the symptoms that the patient complains of, the dilated veins, the varicose veins, reticular veins, and telangiectatic veins, and this in turn leads to edema, lipodermatosclerosis, and stasis ulcers. Backflow also leads to congestion of blood in the veins, which can cause the symptoms that we mentioned, pain, fatigue, heaviness, aching, burning, throbbing, cramping, and the patient may even complain of restlessness of the legs. Now, these symptoms are frequently made worse by prolonged standing. That's why patients who have sedentary jobs, either they are secretaries and they sit at a desk all day typing, answering the phone, they tend not to get up and walk around enough. And also patients who tend to stand in one place. For example, a machine operator who spends most of his shift standing in front of the machine. These patients are affected simply by gravity, and the fact that they're not moving around means that their calf pump does not work and does not push the blood back up. Then we should be looking out for skin rash. There may be small blue veins on the feet, skin discoloration, and ulcers. These indicate an advancing vein problem. What happens with severe varicose veins, which have been present for a prolonged period? They can actually compromise the nutrition of the skin, and this leads to a type of eczema, discoloration, inflammation, and ultimately ulceration. And this entire process is named lipodermatosclerosis. Now, it's important to realize that treatment of these abnormal veins will result in improvement of the symptoms in the majority of patients. DVT is not a known complication of chronic venous varicose veins. Note all the symptoms that I've listed on this slide, and it's very important to remember the red text. DVT is not a known complication of chronic varicose veins. Now, besides the skin color, which may hide the vein abnormalities, all patients may have veins that are abnormal but without any visible changes, without any obvious symptoms or signs. Now, what we need to do besides the physical examination, we still obviously need to do a full clinical examination and carefully look at the patient's lower limbs. The investigation of choice is Colorflow Duplex ultrasound. Right? And the ultrasound can be used to accurately measure vein diameter, assess reflux, and it can contribute to the precise mapping of both normal and abnormal veins in the leg. It is also important to exclude DVT, a personal or family history of clotting disorders, and concurrent arterial disease. This is very important. Patients who do have DVT should not have any type of surgery done to their superficial venous system, right? Because their superficial venous system may be the only route for the blood to return to the heart, because there's a large clot in the deep venous system. So even a patient who has recovered from a DVT, we are generally very hesitant to then operate on the superficial venous system. Obviously, concurrent arterial disease must be excluded. It is possible to get both arterial and venous disease in the same patient. And a lot of the treatment for varicose veins can actually exacerbate arterial disease. For example, compression stockings may result in poor blood flow, the already poor blood flow being further compromised, and this can result in the patient having exacerbation of the arterial disease. Personal or familial clotting abnormalities must be detected. This can be done on history. Patient must be questioned extensively, and you must make sure that there's no evidence of clotting disorders in the patient. Okay, a little bit of stress relief after all that information. It's unfortunate with this format of presentation, there's no feedback. I don't know who's laughing at my jokes, if anyone. Please send through any questions directly to me on my number on WhatsApp. Okay, now what causes abnormal veins? The thing is, a definitive cause is not actually known. You would have noted on the previous pathophysiology slide, we had said primary causes, secondary causes, and congenital causes. Now, we still don't know what exactly these causes are. There are certain associations. There is a strong family history which patients may admit to. Definitely, women are more likely to suffer from varicose veins at an earlier age than men. And in women, the varicose veins tend to fluctuate with hormonal changes, such as during puberty, pregnancy, and menopause, as well as with the use of oral contraceptive pills. Varicose veins is common in pregnancy, especially during the first trimester. There are elevated hormonal levels, and the blood volume is also increased because of the pregnancy, and this causes veins to enlarge. Enlarging uterus also causes pressure within the pelvic veins, and this causes back pressure within the veins of the leg. Varicose veins occurring in pregnancy will often improve significantly within 3 months after delivery. So we generally will not be treating varicose veins in pregnant patients until at least 3 months after delivery, and then only if they are indeed troublesome. There are certain other predisposing factors, such as advancing age. I mentioned standing occupations already, also sitting occupations, and obesity, lack of mobility, previous venous thrombosis. Right? It's important to appreciate that DVT and thrombophlebitis can contribute to varicose veins, but generally chronic varicose veins does not lead to DVT. Also injuries of the leg. Okay, we've got a question here. Can exercise cause further damage? No, actually, exercise, as long as it's done in a controlled environment with a professional such as a physiotherapist or biokinetist overseeing the exercise program. Generally, exercise will not cause or make varicose veins worse. If anything, the activation of the calf pump actually makes the varicose veins better. It will actually help to improve venous return to the heart. Trust that answers your question, Senzo. Now, Jen, thank you very much. He posted that he laughed. Do patients need their varicose veins and spider veins? So, what we're trying to say, is there any harm that the patient can suffer if we actually treat these veins? Now, people are fully aware that varicose, or not varicose veins, the superficial veins are actually used for bypass surgery. Right? Cardiothoracic surgeon will frequently harvest a lower limb superficial vein. Please make note of that. It's a lower limb superficial vein, not the deep venous system. And they will use it as a bypass. They will turn it retrograde so that the valves are not going to occlude the blood flow. And this can be used for bypass surgery on the heart. Now, this is not recommended if the veins are abnormal. If there are varicosities or if there are obvious varicose veins, these veins are not suitable for cardiac bypass surgery. So the point being that you don't have to try and save these varicose veins in the event that the patient develops cardiac ischemia later on and needs a bypass. There are other alternatives. Now, these varicose veins and spider veins are unhealthy superficial veins. They are not functioning properly and they fail to return blood to the heart. Right? So the varicose veins impose an extra burden on the deep veins. They actually lead to a deterioration of function of the venous return system. And to compensate for the lack of function in varicose veins, the deep veins have to work harder. And in some cases, they also become abnormal. Once varicose veins are removed, the blood circulation actually improves. In terms of this cosmetic treatment, spider veins are unsightly, they are abnormal, and they do not serve any biological purpose. However, the treatment of spider veins, isolated spider veins, is truly a cosmetic procedure. And for this reason, a lot of the medical aids don't pay for it. But it's relatively easy to treat, and I'll show you a video clip of that just now. Now, when do you need to treat the lower limbs of the vein in terms of timing? Right? We put an emphasis on early treatment. If you can get to these veins early before all the abnormalities start setting in, the outcome is much better. Now, if there are coexisting complications such as bleeding, right? Varicose veins can actually bleed. If there's phlebitis, superficial thrombophlebitis, if there's thrombosis in these superficial veins, if there are skin changes and obviously ulceration, then the treatment becomes more urgent. In general, it is much easier to treat varicose veins when they are smaller, as early treatment tends to be less complicated and less involved. It is recommended that varicose veins be treated before pregnancy, since the complications such as clotting and bleeding can develop during pregnancy, and it's, as I mentioned earlier, we generally do not want to attempt treatment of varicose veins during pregnancy. Varicose veins that have worsened during pregnancy may not fully recover after pregnancy, requiring more involved and complicated treatment than would have been required before pregnancy, which is another reason to try and treat them before pregnancy as opposed to after. Spider veins should be treated only after the varicose veins have been successfully treated. Treating the spider veins, as I mentioned, is a cosmetic procedure, and there are a number of dermatology cosmetic facilities that are treating the superficial veins without addressing the varicose veins. Right, so it's perfectly fine for them to treat the spider veins after the varicose veins have been attended to, but not before. Otherwise, the spider veins will just recur. Please note, writing in red, isolated spider or reticular veins may be treated with foam sclerotherapy alone. Okay, as long as they are isolated, which means that there's no associated varicose veins. Someone is having difficulty linking. If I can just show you the link should show up as blue. Let me just show you this on the screen if anyone's having difficulty linking. Just give me a second. Let me see if I can help. Okay, I've sent the link. If anyone is having difficulty, the idea is to actually just press on the blue link and it should work. Okay, we've got another question. Thank you very much for the question. A patient with sores on the lower legs and an ulcer starting and diminished blood flow on arterial Doppler in the tibial and dorsalis pedis arteries. Would it be wise to investigate the venous system? Antibiotics did help to improve the rash on the legs. Okay, so this patient seems to have confirmed arterial disease, diminished flow on arterial Doppler. So yes, there's nothing wrong with investigating the venous system. The venous system can be investigated in a non-invasive manner using Duplex Doppler, but the priority would be to actually delineate the arterial problem and to investigate further, possibly by the way of CT angiogram, to assess whether the arterial disease is reconstructible. We would have to prioritize the arterial disease and address that before addressing the possible venous problems. But there's certainly no problem or risk in doing venous investigation, right? Because it's completely non-invasive. Okay, so just to repeat that, patient with sores and ulcers was noted to have diminished flow on arterial Doppler in the tibial artery and the dorsalis pedis artery. And would it be wise to investigate the venous system? The patient did respond to antibiotic treatment and the rash in the legs improved. So yes, I would advise that both the arterial and the venous systems be fully investigated. But the priority would be to attend to the arterial disease first. Okay, the next slide are treatment options. Right, there's microsclerotherapy, which involves the injection of a foamed sclerosing agent, which I'll show you a video clip of just now. You can use the ultrasound to actually guide the sclerotherapy. You can insert a catheter into the larger varicose veins. You can thread it all the way up from a great saphenous vein below the knee, all the way up to the saphenofemoral junction. And you can then inject foam sclerotherapy through that catheter, and you can ablate the great saphenous vein in that way. The treatment of choice for ablation of varicose veins is currently endovenous laser ablation, also abbreviated to EVLA. Then, if the above do not work, you may offer the patient ambulatory phlebectomy. This would also be ultrasound guided. You generally need a duplex Doppler or Doppler ultrasound to identify the areas of damaged veins or diseased veins. And under local anesthetic, these veins can actually be excised. I'll show you a video clip of that as well. Then the open surgery, the classic Trendelenburg procedure, which is stripping of the great saphenous vein, stripping of the short saphenous vein. These operations are still done, but obviously modern surgery, modern technology is all moving towards the less invasive day theater cases. This ambulatory phlebectomy can even be done in the doctor's rooms. So surgery is, as you can see, right at the bottom of the list, but it is certainly required for certain patients. Right, writing in red, reticular or spider veins associated with varicose veins. The large trunks, that is the varicose veins, must be ablated first, and thereafter the superficial veins can be treated with microsclerotherapy, and that's foam microsclerotherapy. Okay, so this is a patient that has telangiectatic or spider veins. Right, it looks like a spider web. These are more bluish, but the classic description is the reddish discoloration. Now I want to show you a video clip.
Yep, you're good to go.
Okay, that is a very fine needle, and that injectable is STD or fibrovein. You can see how nicely it just fills up and ablates these superficial veins. Very fine needle, and as long as you get it into the vein, it's safe. I'll show you the complications of this procedure, which is why it must be done very carefully. Note the direction. The doctor is injecting from below to above, from above to below. All right, so as long as you can get the tip of the needle into the vein, it works very well. Okay, there's a question here. There are many over-the-counter products available. Is there any use of topical skin agents for spider veins? Or, sorry, video is running before I wanted to. Sorry, the question is there any use of topical skin agents for spider veins or oral products for varicose veins? No, I know what you're talking about. There's a huge number of over-the-counter preparations, but really those products are, in my opinion, just homeopathic. They don't really do anything specific. Okay, the veins are a physical abnormality. There's no medication that we have been able to find that actually treats them. Okay, so the same video, this was at the beginning of the video. This is at the end of the video. There's a little bit of bleeding and redness, which, as you know, with any cosmetic procedure will settle after a few days, and the outcome is actually very good. Having said that, there are obviously complications of this procedure. This is another patient. This particular patient fortunately did not complicate, but this is what can happen. This is where possibly some of the foaming agent or STD escaped from the vein and was injected subcutaneously and has resulted in necrosis of the skin. Also, if the wrong concentration, sorry, I forgot the word, the wrong concentration of STD is used, you can get similar complications. The same patient, a couple of days later, you can see the areas of necrosis have actually defined themselves. And obviously this patient is going to be very, very unhappy because the cosmesis is just awful. Okay. Okay, one of the doctors notes that he does not see the syringe plunger pulled back to check if it's in the vein. Concerns about myofascial injection. Yes, this is a risk. Generally, the technique that I prefer to use is to actually use a butterfly rather than the direct vein technique, which is shown in the video. We can just look at that again. Okay, so what the question here is that the surgeon gets the tip of the needle in and he just injects, he doesn't draw back. So that is a possible risk. And the way I actually get around it is to use a butterfly, and as you know, the butterfly, once you get it in, the blood will flow back into the tubing, the plastic tubing, and then I know I'm safe. So I agree with you that this is a bit of a risky procedure, but it seems that this doctor is quite used to doing it. Okay, thanks, Najen. I'll try and attend to that. Okay, now going on to open surgery. The Trendelenburg stripping of the great saphenous vein and or the short saphenous vein is the classic operation, and this is still done today, but we do prefer the more minimally invasive techniques. I'm going to go on to that video now.
Hello, I'm Mr. Mike Brooks. I'm a consultant vascular surgeon, and today I'm going to show you how to do long and then short venous vein surgery. So the patient's on a operating table head down with a vein board to spread the ankles, and the preparation I use is alcoholic iodine, as you can see, all the way down to the ankles. Here we're doing bilateral long venous incompetence. If there's a combined short venous problem, normally we'd start with the patient on their front with an armoured ET tube to protect the airway, and just approach the short venous popliteal junction first, and then sew that wound up, dress it, turn the patient over, and then start again with new drapes. Unlike the short venous popliteal junction, the sphenofemoral junction is a fairly consistent feature. Normally we would incise in the groin crease itself, feeling for the femoral pulse first and obviously going medial to that. You can put a travis retractor once you've opened the skin, and by lifting the travis retractor you turn everything into a three-dimensional dissection plane, and very quickly you can get down to the level of the veins. If it's difficult, or if the patient's quite large, you'll usually find a vein coming from superficial to deep, and you can follow that down. Well, here we're approaching the junction now. There's probably a superficial epigastric vein coming down from above. There we are. And coming in from below will be the long venous vein. So we're taking all these branches separately now. Normally you would divide all of them after tying off with an absorbable suture like Vicryl or Polysorb. What I tend to do is clip one end, tie the other, so you end up just putting one tie on instead of lots of little ones. It's quicker, and you end up with a bunch of small clips in your hand, and you can use that to manipulate the junction. So
So all the clips remain on the long saphenous vein side?
They're all on the junction, yeah. And the junctions are very variable, even between patients, but even between legs, so one side wouldn't necessarily be like the other. There's a whole host of variations. Sometimes the anterior thigh vein will be coming in the common junction, some separately. Sometimes the long venous vein appears much deeper than in others. So be prepared for quite a few variations, and that's true with veins anywhere in the body, really. So here we are, just dividing some of the branches again. So a tie on the patient side of things, a small mosquito on the junction side, and then divide. Make sure you divide every branch so you clean the sphenofemoral junction completely. If you leave any branches there, you are at risk of recurrence. You follow the junction all the way down to the femoral vein. Make sure you can see both sides of the femoral vein all the way down for a centimetre above and a centimetre below.
And the femoral vein's quite deep there in the wound, isn't it?
And don't tie or clamp the saphenous vein until you're absolutely sure you know what it is. Every year there are instances of major vein damage and even arterial damage because people haven't identified the anatomy properly. And although that sounds mad, sometimes it can be quite difficult. So here we are, here's the junction being tied off with a strong absorbable braided suture. And then that bunch of clips can be discarded and the vein remnant can be trimmed off, leaving a decent cuff so that that won't fly off when the vein distends. Some people will doubly tie that, some people might even transfix it, but I think one strong tie should be enough as long as you've tied it properly and you'll notice new veins growing across the space there, almost as if the body's treating the operation like an injury and it's trying to fix it. There are lots of techniques to try and prevent neovascularization. None of them are wholly successful. Some of them involve putting a barrier of something like PTFE in. That does run the risk of infection because of foreign material. So what I like to do is a sort of purse string, if possible, or a Z stitch around the cribriform fascia, depending on how big the hole was. Sometimes with a very complex junction you end up with quite a big hole in the cribriform fascia, in which case it's worth putting a continuous suture in it. Here this is requiring a couple. And hopefully what you're doing there is separating the fascial plane so you won't get regrowth back into the femoral vein. Redo surgery is always more challenging because you've got all this scar tissue. What we tend to do with redo surgery is use the same incision but come down from the inguinal ligament onto the femoral vein and follow that distally so you avoid all the scar tissue. So here we are preparing to strip the long venous vein. What I do is an inversion strip. So we use the cheap plastic disposable stripper, but without putting the big olives on the end, which they will offer you. You can discard. So we've tied that vein around the stripper with a strong vicral tie. The bottom end of the stripper is usually brought out just below the knee. We tend to not go beyond that because of the risk of damaging the saphenous nerve. So here we are. We locate it with a very small vertical incision. Bear in mind the only piece of that stripper we're bringing through is the slight dilatation at the end of it and the vein, so you don't need a big hole here. And you just go through and grab that, and then you can make a little incision over the top of the vein that will allow the end of the stripper to come through, and bingo. And sometimes it's as easy as that. Bear in mind that the patient should be head down, so the bleeding should be at a minimum. The vein is coming down. It's an inversion strip here, so it's turning the vein inside out, minimising the damage along the track. So the next stage of the operation, once you've stripped or avulsed the long venous vein down to below the knee, is to avulse all the branches. Now for these we use small stab incisions. What I found the most effective blade is one of these beaver blades, which is an ophthalmic blade, so it's supremely sharp, disposable, makes a very small hole which heals up with almost an invisible scar. but it's big enough to allow you to grab hold of the vein. I use the Ursh hooks, which come in 3 sizes. Once you've hooked the vein up, you grab it with a mosquito forceps, and then using 2, 3 or 4 mosquitoes, pull the vein out. Always try and have 2 attached to it at any one time. And these are very variable. Some of them come out as big long worms, some of them will fragment. Particularly veins that have been phlebitic in the past will tend to be very friable and very frustrating. The minimum you can do is really just to destroy the vein at that point. The best you can do is to strip the whole thing out, as is happening here. Make a note of how much you've got out through each of the stab incisions, and if you've marked your veins accurately enough at the beginning, then you should be able to assess where the next hole should be, and that way you can remove all the avulsions that you've marked pre-op. The accuracy of the avulsion marking is very important because the holes you're making are very small. You want to minimise the collateral damage that you could do with the Ursh hooks. So very accurate marking, very important at the beginning. And the person who's doing the operation should do the marking. Don't get someone else to do it. At the end of the operation, the groin wound is closed with a subcuticular absorbable braided suture. The stab incisions are closed with steri-strips after the leg is cleaned. I then use gauze and crepe bandage from the toes all the way up to the groin. The following morning that's removed and replaced with a TED or similar compression stocking, which the patient wears continuously for a week, after which time the steri-strips can be removed. And after that, the stocking is worn just during the day for another 2 to 3 weeks. They're told to do plenty of walking, avoid standing still, and whenever they're resting, put their feet up.
Okay, that was the open surgery. Now, the first part of that was the Trendelenburg stripping of the great saphenous vein. I'm going to show you another video clip of the short saphenous vein just now, but what I just wanted to point out to you is that they also showed the ambulatory phlebectomy. Although the patient was under general anesthetic, the ambulatory phlebectomy can be done under local anesthetic. You can actually avulse a fair amount of vein under local anesthetic. Now, someone pointed out to me that the video is blocking out some of the pictures. I just want to show you this post-op picture. So I'm just going to look at that again. This is the post-op picture that was blocked out before at the end of the video. The microsclerotherapy, this is what it looks like. It's quite reddish, there's a little bit of bleeding, but as with most cosmetic procedures, this all recovers very well. Okay, I'm just going back to that because the video of my face was blocking that, so I apologize for that. And those are the complications that I already mentioned. Okay, then there's one more video clip that I want to show you. The short saphenous avulsion is not as extensive.
I'm Mr. Mike Brooks, I'm a consultant vascular surgeon, and today I'm going to show you how to do long and then short venous vein surgery. Okay, this lady's also having bilateral long venous vein surgery, and that will be after we've done the short venous ligation. So the marks you see there are for avulsions once she's turned over on her back. So the sphenopopliteal junction has been previously marked using a duplex or a Doppler probe, so we know exactly where the junction is, and it's a very variable thing. Unlike the sphenofemoral junction, it could be anywhere from being at the level of the skin crease to 5 to 15 centimeters above maybe, so you really need to know where that junction is. So we've got a transverse incision at the level of the sphenopopliteal junction as marked previously. That's then the edges of that are retracted and a longitudinal incision is made in the fascia. This allows you to follow the vein up and down. Some people will do a transverse incision there, but it's far more limiting and doesn't allow you out of some sticky spots. You do need space here in the popliteal fossa to avoid any damage to the nerves. So the fascia is lifted up mobilized. It may be that you can actually see the short venous vein or its continuation, approximately the Giacomini vein, which makes the whole thing a lot easier because you can cut straight down onto that and then follow it up and down until you find the branch going deep towards the savino-popliteal junction. Sometimes that's not the case, so what you have to do is to head downwards towards the popliteal vein. And there we are, so we found the short venous vein, and we're going to follow that proximally to its junction with the popliteal vein. Now bear in mind that this vein is usually going between the two large branches of the sciatic nerve. We're putting a tie around the short venous vein now, and then we'll be following it deep to its junction with the popliteal vein. It's very handy at this stage to have a copy of the duplex scan, and if you've got a very friendly vascular lab, they will have drawn you a picture of the junction, because the way that the short venous vein joins onto the popliteal is very variable. It can join straight onto the posterior surface, it can curl around the side, sometimes it can go up and then down again, and often has a varix on it. The varix is quite a useful trick for finding the junction, as it usually happens just above the junction. There may well be branches of the gastrocnemius veins coming in, and the usual teaching is to divide those as well, allowing you to get a proper flush ligation. You'll often find the gastrocnemius veins themselves are incompetent, but again, that information should be available to you on a venous duplex scan. You shouldn't really be doing short venous vein surgery, in my opinion, unless you've had formal venous duplex done beforehand. So here we're following the vein down now. By distracting it, we're pulling it backwards, pulling the junction upwards, therefore avoiding any direct contact with the nerves on either side. Damage to those nerves can result in a foot drop. It's rare, but it's a definite complication and must be included in the consent. So here the vein's been ligated. What's difficult to show you on the film here is the popliteal vein, but you usually get an awareness of that as you're dissecting down. You can see the vein beginning to expand out. It's quite difficult to demonstrate on the camera here, but it's, as in the groin, you really need to try and do a flush ligation if possible. When the fascia is closed, it's very thin, this fascia, and you find a single suture on either side will cut out, so we tend to do horizontal matrices, just 2 or 3, to close that fascia. Sometimes it's not possible. Sometimes with very large veins the fascia is so attenuated as to not really be of any consequence. But it's always worth trying to close if you can, otherwise people end up with a bulge around the back of their popliteal fossa, and they won't be happy with that. Be aware that there may be a nerve just under there, a branch of the sural nerve, and you really don't want to tether that, which could lead to a lot of neuralgia afterwards, so be careful with what you're picking up. So a few sutures in the fascia, followed by continuous suture in the fat, and then a subcuticular suture in the skin with some stereostrips to close.
Okay, so that's all the videos for today. Now going on to the complications. The lipodermatosclerosis is typically described as an inverted champagne or wine bottle. You can see how the neck of the bottle narrows from the body to the opening, and this can actually be seen on patients quite easily. You can even see in this patient, you can just sort of make out that narrowing. And what happens is that you get a brownish red pigmentation and induration, and this is thought to be related to an iron deposition. and it is associated with venous stasis and insufficiency. Right here, the patient has large tortuous varicose veins. There's high volume venous reflux, which was detected on duplex Doppler, early stasis, and there are already changes on the medial ankle. Remember that there's poor nutrition that reaches the skin, and therefore you start getting these lipodermatosclerosis changes. This is a typical chronic medial leg ulcer as compared to the arterial ulcers, which are more on the lateral aspect. And this is associated with long-standing venous insufficiency. This particular patient has had this ongoing problem for 12 years and was refractory to all types of treatment, including all the complex compression stockings that are available. But these ulcers can be successfully treated with modern varicose veins therapy, which involves endovenous ablation with, for example, an endovenous laser, foam sclerotherapy, and ambulatory phlebectomy. Now, all of those procedures can actually be done as a day procedure, which results in the patient having far less mobility, and they can obviously go home by the same evening. All of these symptoms that we mentioned before are actually resolved after this treatment. And the references are eMedicine, which you can go to yourself if you want to read up further, and this textbook, The Guideline of the American Venous Forum, Handbook of Venous and Lymphatic Disorders. It's currently in its 4th edition. Okay, thank you very much, everyone. It's just past 8 o'clock. That brings us to the end of our first CME. I would now like to post the Mcq test, which you should all receive. And if you click on that, please answer the questions. If you listened carefully to the presentation, all the answers were discussed. If you are having any difficulty, this is the link here. Please consider answering that. And the format of the online CME is that you have to get at least 70% to qualify for the 2 CPD points. So please attempt that. Thanks very much, everyone. I'm now going to be signing out. Thank you for watching.